Hello and welcome to the HealthScore Longevity Report. My name is Nick. I'm a board-certified family doctor with over a decade of clinical experience. I'm the founder of the HealthScore Longevity Program, and each week I bring to you an article I've identified in the peer-reviewed medical literature that focuses on the topic of longevity. I'll describe the findings, place it in the context of what's already known, share with you the discoveries, and make recommendations based on what's been learned. I'll also, in certain circumstances, tell you what I personally do. Today we're looking at the topic of treatment of tobacco smoking. Before we go any further, I want to share with you this picture. This is me a few years ago with AmeriCorps volunteers that I trained to counsel patients in our inpatient hospital in Cleveland to quit tobacco. So this topic of tobacco cessation is near and dear to my heart. For 3 years, I was training AmeriCorps service members to be coaches in primary care practices to help people quit smoking. The article we're talking about today is Treatment of Tobacco Smoking, a Review. It was published in the Journal of the American Medical Association. The review include analysis of 30 systematic reviews, 12 randomized controlled trials, and 7 recent guidelines. Some background. Let's look at how common smoking is these days. In 1965, over 40% of the U.S. adult population used tobacco. Today, that number is 14%. An amazing decrease in tobacco use over the past 60, 70 years. Of those who smoke, 90% started before they were age 18. And tobacco use persists among populations that are of low education, male, young, living in the South and Midwest, members of the LGBT2+ community, people living below the poverty line, the disabled, and certain races and ethnic groups, especially Native American and Alaskan Native. You've probably heard it before, but it bears repeating. Tobacco smoking is the number one preventable cause of death in the United States. People who use tobacco live on average 10 to 11 years shorter lifespans. And it's not all lung cancer. While 90% of lung cancer is due to tobacco use, tobacco is pretty much equally contributing to heart disease and death from chronic lung disease. Tobacco smoking leads to a 4 times higher risk of stroke and heart disease, a 25 times higher risk of lung cancer, and a 13 times higher risk of chronic bronchitis and emphysema. Now, turning to what is causing this harm from tobacco, this increased risk of mortality and these chronic diseases, the mechanism are the carcinogens when you burn tobacco, primarily. There's been a lot of confusion about whether or not nicotine is the problem, because public health officials are vilifying nicotine in their attempt to prevent people from using e-cigarettes. But nicotine is safe. It's the burning of tobacco that causes the problem. There are over 7,000 chemicals in tobacco, and 70 of those chemicals are known to be carcinogens. There's also confusion about what constitutes a smoker and whether it's okay to just smoke a little. I'll have patients come to me and say they'll smoke a cigar a day or a week or a month or on special occasions or a cigarette a day. And they'll not even identify themselves as smokers. But the evidence shows that even low-intensity tobacco use over time is harmful. A prospective cohort study in JAMA Internal Medicine in 2017 of over 290,000 adults showed that for smoking 1 cigarette a day over a person's lifetime, there's a 65% higher risk of all-cause mortality. So there is no such thing as a safe amount of tobacco. enough doom and gloom. The fact is that it's never too late to quit. And the sooner you quit, the more years of life you save. We said that if you smoke, you're going to lose on average 11 years of life. If you quit before age 65, you lose only 7 years of life. If you quit before age 55, you lose 5 years of life. If you quit before age 45, 2 years of life. And before age 35, 1 year of life. So the sooner you quit, the better. But there's no time that's too late to quit. It improves how you function and improves quality of life no matter how old you are, no matter when you decide to quit. All right, now I've painted a rosy picture of quitting smoking. Now, why doesn't everybody do it? Well, the fact is that 2/3 of U.S. adults in any given year want to quit smoking, and 55% of smokers will actually attempt to quit, but only 7.5% will succeed. It's common for people who try to quit to be abstinent for a day or two, or a week, or even a month. But most people who attempt a quit will be smoking again by the 3-month time point. Why is quitting so hard? Why do so many people fail? I can see 3 main reasons. The first is biochemical. When we use tobacco, the nicotine binds to the alpha-4 beta-2 nicotinic acetylcholine receptor in the brain, and this triggers dopamine. This is the reward pathway, the same pathway that's used if we do crack cocaine or have sex or eat food. This is highly pleasurable. And this leads to dependence, which means that if we try to stop smoking, we're going to feel withdrawal. Withdrawal includes feeling restless, agitated, depressed, anxious, losing interest in life. Furthermore, nicotine use causes tolerance. So the more we smoke, the more we need to smoke to feel the same amount of pleasure. That's the biochemical answer. Next is the cognitive behavioral answer for why quitting is so hard. So tobacco over a person's lifetime has been ingrained as a very rewarding behavior to do in response to situations. Maybe the situation is feeling anxious. Tobacco relaxes. Drinking a cup of coffee. Tobacco is a very pleasurable accompaniment to drinking a cup of coffee. Maybe it's drinking alcohol. Tobacco enhances that experience. So tobacco becomes intertwined with all of these events or emotional states in our lives. And overcoming addiction to tobacco is not only overcoming nicotine, it's also overcoming these ingrained behaviors. And finally, the reason that quit rates are so low is because most people, 69% of smokers who try to quit, will try to do it on their own. And it is a tough uphill battle. And this is a misconception that it's all a matter of willpower, that you should just white knuckle it through the agony of quitting tobacco. In fact, there are highly effective tools to help you with this quit, so it doesn't have to be a complete battle of will. And this brings us to what works for tobacco cessation. It's a combination of pharmacotherapy and behavioral support. If you take a population that tries to quit on their own, they have an 8.6% likelihood of success. If you take a population and give them both pharmacotherapy and behavioral support, they have a 15.2 likelihood of success. So they have an 83% increased likelihood of being successful with both pharmacotherapy and behavioral support. Okay, a little bit further description. The pharmacotherapy, according to this review article, first-line options are Chantix or varenicline and a combination of a nicotine replacement therapy. So Combination means you use a patch, and then you add to that a gum, a lozenge, a spray, or an inhaler. One of those four plus the patch. Those are the two first-line options. They have about a 22% increased success rate for quitting tobacco when used compared to not using anything. It used to be that in primary care, we would wait for someone to be ready to quit before offering these products. The current understanding is you just offer them to anyone. First of all, there's no harm in using these products while you continue to smoke. Second of all, you are more likely to be able to quit smoking, even if you don't say you're ready and want to this moment, if you have these products on board. They will lessen your dependence on tobacco, make it easier to set a quit date, decide to quit, and eventually give up tobacco. And finally, the traditional thinking was you treat someone for 12 weeks with these products, but a newer understanding is that you treat them for however long they need it. A lot of clinicians will prescribe these products for 6 months, but prescribing them indefinitely is a common practice as well. The fact is that these products are a lot better than tobacco. And if a person is using these products and is likely to go back to tobacco if they stop, it's better to stay on these products. And finally, I promise finally, but this is really finally, these products are covered by insurance, and the combination nicotine replacement therapy is able to be purchased over the counter. Now, I want to just go a little bit more in depth on varenicline because it's so cool how it works. It's called a partial agonist of the nicotinic receptor. So we said that normally nicotine binds to the nicotinic receptor, causes dopamine release. If you try to go cold turkey, then you basically have a lot less dopamine that gets released and you feel like crap. What varenicline does is it binds to the nicotinic receptor in such a way that triggers dopamine, but also blocks nicotine from working. So you get the pleasure from the dopamine release, but there's no added pleasure from using tobacco. The nicotine is no longer able to work at the nicotinic receptor. Isn't that cool? And a couple of notes about combination nicotine replacement therapy. So the recommendation is use a patch. These patches are put on a hairless site of your body and rotated every day. So on your stomach, on your thigh, on your shoulder. And you rotate the patch to a different site each day to avoid skin irritation. They can be worn over 24 hours, but if it makes you restless at night, you can take the patch off before bedtime and put a new patch on the next morning. So you have the patch giving you this steady supply of nicotine, and then you add a gum, lozenge, spray, or inhaler. I'll talk about the gum. It's the most popular. The gum has a much faster, about 30-minute onset of action, and it's meant to be used in addition to the nicotine patch. The nicotine patch is giving you the steady release of nicotine. If you have or anticipate moments where you're going to need more nicotine, you use the gum. It's generally recommended you use one piece every hour while you're awake for the first 12 weeks. A lot of people will say they tried the gum and it didn't work. The fact is that this gum takes a technique to use called chew and park. So you have to place the gum between your gum and your cheek and let it sit there. Chew it a couple of times, let it sit there again. The nicotine gum is absorbed through the mucosa of your mouth, not by swallowing the juice. If you chew it like regular gum and swallow the juice, all you'll get is an upset stomach. While we're on the topic of medication, let's talk for a moment about e-cigarettes. These are devices that use electricity to aerosolize nicotine, and they're very popular among people trying to quit tobacco. I'll tell you the good and the bad. First of all, they're not studied by the FDA and FDA approved for quitting tobacco. So if you talk to most doctors in the US and most clinicians, they're going to say, yeah, e-cigarettes are probably better than tobacco, but even better still would be using an FDA-approved product like varenicline or combination nicotine replacement therapy, for which there's long-term safety data. The good news is that a 2021 Cochrane systematic review of over 16,000 people comparing e-cigarettes to the nicotine replacement patch found that e-cigarettes were more effective than the patch, and e-cigarettes were safe for up to 2 years of use. Now, critics will point out that there's no long-term safety data on e-cigarettes. So, frankly, if I have somebody who's using tobacco and wants to switch to e-cigarettes, I will applaud that move. I think in the long run, it's better to be off these products, but as an alternative, a substitute, and a transition away from tobacco, absolutely you're better off. And in the UK, clinicians actually encourage e-cigarettes for quitting tobacco. We've talked about pharmacotherapy, but the other side of the coin is behavioral support. 44% higher likelihood of quitting when you add behavioral support to medication alone. Now, behavioral support comes in all shapes and sizes and all types and flavors. Some of the common elements are enhancing a person's motivation to quit, so having them articulate reasons for quitting. Behavioral support includes usually setting a quit date at a point in which you will completely stop using tobacco. It encourages adherence to whatever pharmacotherapy was prescribed. It raises awareness about withdrawal symptoms so a person can anticipate them and can use the nicotine replacement product or know that varenicline is going to help through this. It talks about triggers, environments where the person associates smoking, and either staying away from those triggers or planning to manage those triggers in different ways other than using tobacco. And it also generally includes discussion about the importance of social support, recruiting those friends and family around you to support you in your quit attempt. In addition, it provides that social connection in itself. These behavioral support programs have been shown to be effective in person, by video, by phone call, by text message, by apps. So there's many ways of going about availing yourselves of behavioral support options. The bottom line is, as we said, tobacco, number one cause of preventable death. No such thing as a safe amount. And the best way to quit is the addition of pharmacotherapy to behavioral support. What I recommend, I have compiled my 10-step program for quitting tobacco into a download that you're free to access by clicking at the link below. This outlines the pharmacotherapy options, the behavioral support options, and takes you through a 10-step process that has worked for thousands in helping them quit using tobacco. Thank you very much for joining me on this week's edition of the HealthScore Longevity Report. I encourage everybody to join my Facebook group. You'll see the link to it below. This will enable you access to all of the PDFs I create, the HealthScore tips on all of the topics. You'll be able to join discussions over health and participate in Q&As weekly with me to answer any questions you might have. Please join us next week. We're talking about a study that looks at the connection between being overweight and developing diabetes. Have a great week and take care.